Good evening, everyone. And sorry, we took some time to start because one of our webisodes was Zoom bombed. So that's almost like hacking of the uh, Zoom meeting. So where you get a lot of computer generated voices and content. So we've started doing some of the security measures. So this is the last webisode in our series of esophagus and GE junction tumors. We have so far discussed esophageal cancer, the basics of it, the neoadjuvant treatment, the surgical aspect of esophageal cancers, and the treatment for metastatic and unresectable cancers. Now, we are always intrigued by GE junction tumors because they fall in someone's called no man's land. So they are neither esophageal nor gastric. And even today, when I see a patient of GE junction tumors, I'm not very sure. So we have to decide on each and every case, individualize how much esophagus, how much stomach, how much lymph node dissection. So this is a very interesting topic from that perspective. So we have got a very wonderful panel and a speaker to address these issues to tell us what to do in such patients. So we would like to welcome Professor Inian Samarasam. He is Professor of Upper GI Surgery at CMC Vellore. We also have Dr. Sanjeev, who is a dear colleague and excellent surgeon. So he will be moderating the next, the panel discussion. And then we have Dr. Saurabh Kalia, who is a GI surgeon at Narayana Hospital, Jaipur. We have Dr. Biswajit Dubashi, who's a medical oncologist at JIPMER, Puducherry, and he again specializes in these tumors. And Dr. Joseph from Rajagiri Hospital is an excellent GI surgeon. And Dr. Abhishek Gulia. Good evening, Dr. Abhishek. And he is a senior radical oncologist at Jaypee Hospital in Noida. So with this, I would request Professor Samarasam to enlighten.
Yeah, thank you, Dr. Nikhil. Am I audible?
Yeah, absolutely, sir.
Okay, sure. So, thank you very much for the invitation and for asking me to participate today. Uh, and congratulations on conducting this successful webinars on GI surgery and surgical oncology. Uh, so, a very good evening to everybody who have tuned in. So, my brief is to talk on GE junction tumors and, in particular, about the surgical management of junctional tumors. Junctional tumors, as we know, the incidence is increasing in the West, and a similar trend has been observed even in the East and in our country, possibly due to changing dietary factors, perhaps obesity, reflux disease, etc. And as Dr. Nikhil was just alluding to, junctional tumors do provide challenges, not only because of the anatomical location, perhaps also because of the lymphatic pathways encompassing both the abdominal chest cavity, sometimes even in the neck, and of course, the technical challenges associated with surgical operation. So, starting with an upper GI endoscopy, uh, it's not only the biopsy, but accurate location of the tumor, its length, its circumferential involvement, the degree of obstruction, if any, if there is presence or absence of Barrett's, and trying to then work out what type it is based on the SIVA. So these are all components of an upper GI endoscopy. And I should perhaps say here that the surgeon should probably do the endoscopy if possible, or at least be there when it's being done, because it gives a lot of information that you can base your decision of what to do on. Of course, I'm not going into the details of the staging investigation, but just touching upon each one of them. A contrast enhanced CT of the thorax and abdomen is crucial, gives a lot of information about the local extent of the tumor and also the presence or absence of metastatic disease. What about a PET CT scan? Is it always necessary in junctional tumors? A PET CT upstages the tumor and upstages the disease in about 20% of cases. So, really speaking, in T3 or T4 tumors, that is tumors which are advanced, perhaps CT scan plays, PET CT scan, I should say, plays an important role. And if it is early disease, perhaps T1, T2, then you don't need a PET CT. What about staging laparoscopy? Staging laparoscopy for Sievert's 1 tumor, that is the more proximal tumors, is optional. However, for Sievert's 2 and 3, it's certainly necessary. And why staging laparoscopy? Because we all know that it can change the management in up to about 40% of patients. And you can obviously avoid an unnecessary laparotomy in up to about 20 patients. This is after all your staging. And when would be an appropriate time to do the staging laparoscopy? Now, if you look at the sequence of events, you've got the preoperative staging, then perhaps you would put these patients through some form of neoadjuvant therapy, restage, and then do surgery. So the ideal time to do a staging laparoscopy is before you start the neoadjuvant therapy. Why? Because it gives you the most accurate staging. You can miss small volume peritoneal disease. And if you actually do it here, just before the surgery here, after the neoadjuvant therapy, and if you see peritoneal disease at that point in time, you're unsure whether the patient has progressed with the neoadjuvant therapy or whether this was perhaps even present even before. So the ideal time to do it would be here. It will, if you do it here, involve another separate operation, but it is certainly worth the time and effort. When you do a staging laparoscopy, peritoneal fluid cytology plays an important role. You have a very small subgroup of patients who may be cytology positive but no macroscopic peritoneal disease. And in this subgroup of patients, obviously, the prognosis is adversely affected by the peritoneal cytology being positive. So it's good to know whether it is positive or not. What about endoscopic ultrasound? It's an accurate way of staging both the T stage and the end stage disease. It is particularly useful in early stage disease. We don't see this that many T1, T2 in our clinical practice, but if you do see one, an endoscopic ultrasound is very useful in deciding on the staging, deciding on the need for neoadjuvant. For example, if you have a T2 or a T1, you may not give neoadjuvant, go upfront surgery. And obviously, if you have a suspicious lymph node away from the primary tumor, it may be helpful in the assessment. If you come to junctional tumors in particular, endoscopic ultrasound perhaps not that helpful because you have this diaphragmatic movement at the hiatus, which can hinder in the actual assessment. And of course, what we see in clinical practice is obviously advanced stricturing and obstructive lesions where EUS may be difficult and not even possible. Now, coming to the question, are these junctional tumors? How do you then look at them? How do you then treat them? Do you treat them as gastric? Do you treat them as esophageal? So basically, the 8th AJCC, if the epicenter of the tumor is within 2 centimeters of the junction, then it is treated as a esophageal tumor. Whereas if the epicenter is more than 2 centimeters away from the junction, then, or if the tumor doesn't even reach the junction. So in these 2 scenarios, it is treated as a gastric tumor. Now, what are the implications of that? So if you have something like this, then because you're treating it as a gastric tumor, gastrectomy or complete removal of the stomach will form part of your surgical treatment. Now, The classification of junctional tumors, we are all aware of the Sievert's classification. So I don't have to spend too much time on this. But basically, it depends on the epicenter of the tumor. So it's not the proximal extent, it's not the distal extent, it's the center of the tumor. So the center of the tumor is in the blue area shown here, then it is Sievert's 1. If it is in the purple area shown here, that is 1 centimeter above or below the actual junction, then it is type 2. Or if it is beyond that towards the stomach side up to 5 centimeters, it is Sievert's type 3. The Japanese counterpart of the Sievert's classification is the Nishi's classification. And that is shown here at the bottom here. And basically in the Nishi, it is 2 centimeter above and below. So beyond that, they don't look at it as a junctional tumor. And if you look at the picture above, so that is the corresponding types in the Sievert's. So essentially, there are 5 types in the Nishi classification based on where the predominant tumor is, whether it's on the esophageal side or whether it's in the gastric side. And the middle 3 are the true junctional tumors or the cardiac tumors. Of course, all for the management, these have to be discussed preferably in a multidisciplinary setting because you need the input of a number of people because like any other cancer, it is multidisciplinary. When would you give neoadjuvant therapy? Just very briefly, if it's a locally advanced tumor more than T2 or if there is N1 disease, regardless of the T stage. So this is the indication for giving neoadjuvant therapy. Of course, the patient should be medically fit for whatever type of neoadjuvant therapy you decide to give, be it radiotherapy, chemoradiotherapy, etc. Because this patient is going to have a big operation at the end of your neoadjuvant therapy. The popular ones, if you look at the NACRT, which is the cross regime, and if you look at the chemotherapy, it's the FLOT, which is basically docetaxel, oxaliplatin, 5-FU, and leucovorin. So 4 cycles before, 4 cycles after surgery. And of course, in our patients, probably, a little bit of compliance issues with FLOT. But in our practice here in our institute, this is the predominant chemotherapy, neoadjuvant chemotherapy that we give. As far as our practice is concerned, if it is a squamous cell carcinoma, then we go for the cross regimen. If it's an adenocarcinoma, for example, a junctional adenocarcinoma, we would give chemotherapy, and our chemotherapy of choice is the FLOT. And if you actually compare cross versus FLOT, there are quite a few ongoing studies. In fact, the NeoAges, they have come out with their results, and there is an equipoise with cross and FLOT. The results have just come out. If you look at the Esopahgeal and the Japanese trial, the next, the results are yet to come. But it would be interesting to look at what it is. But in our current practice for junctional adenocarcinomas, we give NACC. Okay. Another space to watch would be the immune checkpoint inhibitors. The results of this trial, which is the Checkmate, has just come out. I'm not going to go into the details, but this is a space to watch. Of course, the Keynote trial, which is again looking at the same checkpoint inhibitors, yet to come. Now, I'll move on to the surgical part, which is what I was told to concentrate upon. So basically, the surgical management principles differ when it is a squamous versus an adenocarcinoma. So I'll first start with the squamous cell carcinoma. Now, squamous cell carcinoma, as you see on the left side of the screen, the treatment, regardless of the location of the tumor, is a total esophagectomy. Why? Because of this phenomenon called field cancerization, which we are all aware of. So whether it's just above the GE junction, whether it's involving the middle of the thorax, the treatment would be a total esophagectomy. So for squamous cell carcinomas, it's reasonably simple and straightforward. Now, if you look at the lymph nodal spread, squamous cell carcinomas, depending on their location, can spread proximally and distally. So therefore, an appropriate lymphadenectomy would be at least a 2-field lymphadenectomy. In some centers, they include the neck as well, which would be a 3-field lymphadenectomy. So for squamous cell carcinomas, it's pretty straightforward, regardless of where they are. So the treatment would be a total esophagectomy, a lymphadenectomy of the abdo, chest, plus or minus neck. You would use the stomach as a conduit most of the time, and you would do a neck anastomosis because you're doing a total esophagectomy. The alternative would be a transhiatal esophagectomy, where you don't open the chest, obviously, and the anastomosis is in the neck. Now, it gets a little bit more complicated when you come to adenocarcinomas. Now, if you come to adenocarcinomas, now, as far as the margins are concerned, you would like to give about minimum of 2 centimeter margin, up to 5 centimeters if it is bad biology tumors. Okay, and of course, you need to do an adequate lymphadenectomy. Now, if we look at the lymphadenectomy part, now, if you have a Sievert's 3 lesion, so basically predominantly involving the stomach side, just reaching the GOJ, the nodes that you would perhaps need to remove on the thoracic side or the mediastinal side is just the lower esophageal lymph node. So you don't have to go very high in the mediastinum, because the incidence of these nodes being involved is fairly less. Of course, you will have to do a complete D2 dissection in the abdomen, which is station 1 to 12. So that would be for a Sievert's 3. Now, if you look at the lymphadenectomy required for a Sievert's 2 junctional tumor, here the tumor extends a little bit more into the esophagus. So perhaps your lymph nodal involvement is going to be more, as you can see here, at least up to the carina level. So your lymphadenectomy should perhaps include up to that level. But when you go to the abdomen, you really don't have to you don't have to do an entire D2 dissection. So you remove the lymph nodes along the lesser curvature, station 7, and perhaps the celiac. So you can confine your lymphadenectomy to the lesser curvature part of the stomach, because the chance of the nodes along the greater curvature, which is 4, 6, and 5, so propyloric and propyloric, the chance of those being involved is less than, is about 1 or 2%. So therefore, you do not have to do a lymphadenectomy on the greater curvature of the stomach, and therefore you will probably be able to use the stomach as a conduit in these patients. If you go to Sievert's 1, which is more proximal tumors, you will have to do a complete mediastinal lymphadenectomy. Again, you can confine your lymphadenectomy to the lesser curvature of the stomach and the celiac axis. So that's about the lymphadenectomy requirement when you look at the junctional tumors. And to summarize, so basically, if you've got a type 1, which is on the left side of the screen, so you've got a tumor involving part of the esophagus. So you need to give a margin of at least 2, maybe 5 centimeters. So that's going to involve an esophagectomy. Of course, you give a distal margin, which will involve part of the lesser curvature of the stomach. Your nodal lymphadenectomy should involve at least up to the carina level in the mediastinum, and you will remove the nodes along the lesser curvature and the left gastric artery in the abdomen. Now, if it's a type 3, so this is basically, this will involve either an Ivor-Lewis esophagectomy or a McEwen's esophagectomy. Of course, you may do a transhiatal also. Now, On the right side of the screen is the type 3 lesion, where it is predominantly in the abdomen. So your operation will therefore involve a total gastrectomy. You will probably remove, give a margin of 2 centimeters, 3 centimeters at least to get to the lower part of the esophagus. And you will remove the lymph nodes. You will do a proper D2 lymphadenectomy with nodes along the lower part of the periesophageal lymph node should be adequate. Uh, the real gray area is the type 2 lesions, where you could end up doing one or the other. Okay, so that is the real gray area in this. And this slide is basically what we've discussed so far. So basically, if it's an SEC, it's fairly straightforward. It's McEwen's or a transhiatal. If it's a type 1, then esophagectomy, gastric pull-up with a neck or a thoracic anastomosis. An alternative would be a transhiatal. If it's a type 3, it's a total gastrectomy with a jejunal anastomosis. And depending on the whether you can reach it through the abdomen or not, you may have to open the lower left or the right side of the chest to do the anastomosis if required. So that is for type 3. But for the type 2, it could be one or the other. So we will then go on to sort of deciphering what we do for type 2 a little bit later. So what are the practical difficulties when you decide or when you have a junctional tumor? So obviously we talk about 2 centimeter above, 3 centimeters above, but where exactly is the GOJ? That itself can be difficult to determine because it's very difficult to localize it on endoscopy, radiologically, laparoscopic assessment, whatever you do, it is still a guess. Okay, and there can be still inter-observer divergence when you actually calculate where exactly the gastroesophageal junction is. Now, this can be even more difficult when you got a large tumor or when you got, for example, a hiatus hernia associated with the tumor. So all this can make it practically difficult to exactly decipher where the gastroesophageal junction is. Now, again, large tumors may straddle two sievert groups, and the epicenter, we talk about epicenter, but that can also be hard to define. And if you look at how much of discordancy for even like for a type 3 lesion, there was a study looking at it, and there was a 40% discordancy between experienced clinicians. So it's not very accurate. But the most important, I feel, the problem with both Sieverts and the Nishi classification is they refer to they base the treatment based on the epicenter or the center of the tumor. Okay, because type 1, type 2, type 3, we talk about the center of the tumor, but they do not actually look at the proximal or the distal extent of the actual malignancy. And that is a major problem in decision making. Now, we all know practically that this is what we face, but just to put it into perspective, if you look at Sieverts 2, which is the real gray area, this is a fairly straightforward Sieverts 2. Okay, so because you got the epicenter of the tumor here, if you've localized where the GOJ junction, gastroesophageal junction is, and it is extending on either sides, it's a fairly straightforward thing, and it'll be a total gastrectomy for this. Now, if you look at the picture on the right of the screen, now where is the epicenter of this tumor? This is again in this purple area here. So this is again a Sieverts 2 according to the Sieverts classification. But how can you do the same operation for this on the left side and for the tumor on the right side? It is just not possible. So the problem here, as you can see, is that this classification does not take into account how much of tumor extends proximally, how much of tumor extends distally into the stomach. So if you really want to solve this puzzle, I think you got to ask three questions. Okay, first is what is the longitudinal extent of the lesion? So in other words, you have to look at the proximal and distal and see how much of margin you need to give. You need to answer the question, how much of an adequate lymphadenectomy and how am I going to achieve it? Can I achieve it through the abdomen itself, or do I need to go into the chest? And the third question you need to ask yourself is, what conduit am I going to use? So these are the three questions that you need to ask to solve this question or problem. So if you look at the first thing, so if you look at the proximal extent of the lesion, if the upper extent is, or the upper border of the tumor is, say, 2 to 3 centimeters above the gastroesophageal junction, uh, perhaps you can, if it is less than 2 to 3, then you can approach it through the abdomen. But if it is more than, let's say, 3 centimeters, you will need to go into the chest uh, to give an appropriate margin for your anastomosis. The second thing that the upper extent of the tumor will help you is to decide the extent of mediastinal lymphadenectomy. Okay, so if you have a tumor that is less than 2 centimeter above the gastroesophageal junction, so in other words, if it is just going on, you just need to do a lower mediastinal lymphadenectomy through the hiatus. If the tumor is between 2 to 4 centimeters, then you will need to go at least up to the carina to do some a decent lymphadenectomy. Or if it is more than 4 centimeters, I'm talking about the upper extent of the tumor. If it is more than 4 centimeters above the gastroesophageal junction, then obviously you need to do more mediastinal dissection, and this may be supracarinal lymph node dissection as well. So that is about the upper extent. What about the lower extent of the tumor? What does that imply? The lower extent or the extent of stomach involvement will help you decide, is this patient going to require a gastrectomy or not? In other words, can I use the stomach as a conduit or not? So if you look at it, if the longitudinal extent of the tumor is more than 5 centimeters, or if the majority of the tumor is below the stomach with an epicenter more, if it is more than 2 centimeters from the GOJ, the second point is basically if the predominantly it's in the stomach, or if the tumor involves a fundus in the body. So if any of this is present, obviously you will need to do a gastrectomy, and of course you cannot use the stomach as a conduit. So if you break it down into these three things, one, looking at the upper extent, one for the margin, looking at the upper extent to look at the need for or the extent of mediastinal lymphadenectomy, and looking at the lower extent to decide on whether you're going to do a gastrectomy or not, will probably make things a little bit easier. It's not foolproof. You will still have questions to answer. There may be ambiguity, but these are the bare minimum that you need to do to come to a decision. So let's look at this example. So you've got a tumor. The tumor is probably about, let's say, 4 centimeters above. So based on the upper margin, you will need to go into the thorax for an anastomosis. Based on the upper extent, which is 4 centimeters, you will need to go into at least the middle of the median. At least the subcarinal lymph nodes needs to be up to the subcarinal lymph node needs to be clear. And based on the lower extent of the tumor, you can still use the stomach as your conduit. So an operation would be either an Ivor-Lewis esophagectomy or a McKeown's esophagectomy, or if your center does a transhiatal esophagectomy, that's perhaps okay, but your lymph nodal clearance may not be that adequate. So that is for this tumor. Suppose you have a tumor like this. So this is, let's say, 2 centimeters. 2 centimeters, you could perhaps manage from below itself. So you can do a total gastrectomy based on this. Upper extent, again, 2 centimeter, you don't need to go into the mediastinum or the subcarinal nodes. You can just manage with the lower esophageal nodes. And of course, you're going to decide to do a gastrectomy. Suppose you do an Ivor-Lewis, you will be able to use the stomach as your conduit. So this is, again, something like that. If you have a tumor like this, here the tumor is extending, let's say, 4 centimeters above. So you will need to go into the chest and do an esophagectomy. You will need to go into the chest to do at least up to the subcarinal lymph nodes, and you cannot use the stomach as a conduit because it's involving a significant part of the stomach. So for this patient, you would do a total gastrectomy probably an extended total gastrectomy involve removing at least giving a 2 centimeter margin, and you will probably be using the jejunum as a conduit, and you certainly cannot be doing the anastomosis from the abdomen. You will probably need to go into the chest. So if you look at so this is a good way of looking and solving this issue. Now coming to, apart from the upper, lower extent, etc., there are other factors which help in the decision, which may influence decision making, which includes the tumor grade differentiation, whether there was a obstruction to the esophagus, what type of neoadjuvant therapy you give. Suppose you have a very obese individual, then in order to do a safe anastomosis, you may have to go into the chest, whether there is a suspicion of more proximal mediastinal lymph nodes, whether your jejunum is going to reach, okay, and also the type of patient, like if it is an elderly patient, or is it a fit young patients where you would go onto a radical approach. So all these have to be, so it's a tailored approach for each patient. One size does not fit all. Now, if you and when you're doing the operation, if you have a type 2, so let's say you start in the abdomen, you start with the trial dissection in the hiatus. Of course, an intraoperative endoscopy will help you to look at the location of the tumor, and always in such cases do an intraoperative frozen section, which will help you decide whether you are able to achieve the margin or not. I will briefly touch upon colon. If you cannot use the stomach, if the stomach needs to be removed, and because of a large tumor and also esophagus is involved, or if the stomach is unavailable because of previous surgery or previous gastric resection, let's say a sleeve gastrectomy for obesity, patient develops junctional cancer, then you will need to do some other conduit. And if the jejunum will not reach, then colon is the substitute that we normally use. Now, also, what is the role of proximal gastrectomy? We've been talking about total gastrectomy, esophagectomy, etc. What's the role of proximal gastrectomy in these tumors? Now, please understand that the standard surgical procedure for a clinically node positive or an advanced tumor, that is T3, T4 of the stomach or GOJ, is a total gastrectomy. So when can you do a proximal gastrectomy? When you've got early disease. So if it's a T1, T2 tumor, or if there are no nodes, or if it's a low risk tumor, it's grade 1, 2 intestinal type with none of these present, that is when you can do a proximal gastrectomy. Why can't you do a proximal gastrectomy for advanced gastric cancers? Because for an advanced gastric cancer, these are the lymph nodes you need to remove. And if you're doing a proximal gastrectomy, you're going to leave behind these group of lymph nodes. If you're going to do a proximal gastrectomy, it may be okay if it's an early disease, which is T1, T2, but it may not be okay if the patient has got locally advanced tumor. So you need to be careful in selecting whom you perform a proximal gastrectomy upon. Molecular subtyping is coming, so we will certainly be seeing more in this space, not only in the adjuvant neoadjuvant setting, but also in deciding what type of operation to do. And in the 9th edition of the AJCC, this is also going to be incorporated. I'm not going to be talking about the minimally invasive. So the principles, we know minimally invasive is much better in terms of morbidity, etc. But for want of time, I'm not going to be going on this. So I'll conclude. So management of junctional tumors, basically it's a balance between the appropriate surgical approach, which depends on your ability to do an R0 resection, both proximal, distal, circumferential, your ability to do an adequate lymphadenectomy, and you should perform it with the least invasive technique. When I say least invasive, if you can manage through the abdomen, that is the most appropriate operation. But you cannot compromise on the margin if necessary. And of course, the type of neoadjuvant therapy also will define and decide what surgical approach is taken. And you need to balance that with other factors, such as the patient fitness, the safety of surgery, quality of life issues, the surgical expertise that is available, and of course, local practice. It's very important because that is going to determine what you're comfortable with. So all these factors put together uh, is the key to the management of these tumors. Thank you for your kind attention.
Thank you, Professor Samarasam. It is actually very informative, and even in brief 30 minutes, you have covered up most of the things which we are mostly like decision-making problems. And so I have a couple of questions here. If somebody also has question, they can ask, and they should ask. So one, like, is there a role of Ivor-Lewis for squamous cell cancer?
So basically, for squamous cell cancer, you try to remove as much as possible. So the esophagus, you don't want to leave behind the esophagus, particularly in the chest. So I would say for a squamous cell carcinoma, regardless of the location, it would be a total esophagectomy or a near total esophagectomy, unless there is a reason where you cannot do it. So if there is any particular reason, but generally speaking, for a squamous cell carcinoma, it will be a total gastrectomy, which is either a McEwan's or a transhiatal.
So, I mean, in the specific context of this GE junction cancers, if the extent of gastric resection required is so much that we can't do a McEwan.
Yeah.
So then the next option would be a colon transposition. So in such circumstances, would you want to do?
Yeah. So basically, you're asking a circumstance where extensive stomach involvement, lower esophageal involvement, and your choice between using the jejunum as a conduit versus the colon as a conduit if you need to go into the neck.
Not
right?
really,
Okay.
sir. So what? No, the case scenario which I am thinking of, where the gastric involvement is such that you can get away with a partial gastrectomy, and stomach is big enough to reach thorax, not the neck.
Okay. Yeah. I guess still I would say for a squamous cell carcinoma, it is not standard practice. You would still, but it depends on the patient. Like if it was a young patient, I would still do a McEwan's esophageectomy. If it was, other factors which is going to determine the thing, I will probably modify it.
Okay.
I have a question.
Yes, please.
Yeah, please, Dr. Saurabh.
Yeah, actually, very nice talk, sir. I wanted to ask that if you have a patient with a type 2 where there is extensive involvement, and after neoadjuvant therapy, it has regressed. So would you base your decision of the surgery based on the previous or the recent CT findings? Because it may change. The stomach involvement may not look that extensive later on, and you may need to you may decide not to remove the whole of the stomach then.
Sure. No, that's an excellent question, and I forgot to mention that in the talk. So basically, your decision making is pre-neoadjuvant therapy because that is why you need to be very accurate in deciding what you are going to do. And once you start the neoadjuvant therapy, you can have a complete response also. So then, how are you going to decide? So basically, your decision making on the margins, etc., is going to be defined by your pre-neoadjuvant therapy staging, pre-neoadjuvant therapy margins. Of course, once you do the neoadjuvant therapy, your margin is going to shrink, and unless it is extremely rare circumstances, you will base your margins on the original original staging before the neoadjuvant therapy rather than after. I think that is a very, very good question.
Thank you.
We have one question from Dr. Jagannath. I'd request him to unmute himself and ask.
Hello, good evening, sir. Thanks for the opportunity. And yeah, it's an excellent presentation, Dr. Inian. I think you have covered most of the practical points in the discussion. But I have got some question. I do more of this minimal invasive surgery with the robotic, but most of the time, no, we do either proximal gastrectomy and total, but the proximal margin, sometime we are not sure whether it is positive or is it close or whether it is far. That time, we might have to put the specimen into endo bag and retrieve, and then again close abdomen and continue the anastomosis with the minimal invasive surgery. So there is, the loss of time and the, need additional manpower and all that. In these circumstances, on table, either some scopy or you advise the retrieval of specimen and take some margin frozen if you are not sure. How do you proceed in this condition?
Yes, sir. So basically, as you rightly said, on-table endoscopy, certainly when you have junctional tumors where your margin is going to be doubtful, is very, very useful. Of course, it takes a little bit extra time and effort to do it, but that is one of the things which is very useful. To be honest, we don't do it all the time, but if there is any doubt or if there is an issue that we are going to face, at least we do it the day before the operation to make a reasonable decision. But have it available in drop is very, very useful. And number two is you asked about the frozen section. I think it adds so much of value to your anastomosis if you're able to do a frozen section. So I think in such kind of tumors, a frozen section is crucial. Now, with regards to minimally invasive versus open, regardless of whatever approach, our aim is to get a negative margin, and I guess we should strive to achieve that. The approach is only a ways and means of achieving it, but we cannot compromise on the margins. Is what
yes, sir. Yes, sir. Excellent, sir. But I feel that whenever we go higher up, most of that, whatever the distal esophagus which is seen through the abdomen, but once you cut and it retract, goes almost into the subcarinal region. I think most of the time we have landed up in doing a left thoracoabdominal, because I think this Tata group from the TMH, they are very pioneer in doing, rather than Ivor Lewis, they always believe that just put a little lateral position and give some support to the back and just do the left thoracoabdominal with a smaller incision, but still you can reach up to, say, into the subcarinal region. But for a proper, the removal of all the lymph nodes, I think still Ivor Lewis stands still the gold standard. I think I had some challenges with my surgery where esophagus gets retracted. Either you can't put the endo staplers or the circular staplers, and most of the time you had to have a robust guy retracting the lungs, and it keeps beating the heart, and all that. You'll have a less space to put the hand and all that.
Sure.
So I think this quite the critical decision, either to go through the right thorax or the left thoracoabdominal, is a little challenges, but it keeps on. I think whenever we get a thin patient, we are happy with a BMI of 22, 23, 24. But whenever we see a obese patient, I think there's a lot of physical struggle which happens. I think each case, as you said, it has to be individually managed and properly planned. I think that's what I just wanted to
sure, sir. Yeah, completely agree.
One more question.
Yeah, thank you, sir. Thank you.
Yes, sir. Thank you.
I have one more question. Sir, as you said, the type 2, there's chances that you may need to remove the whole of the stomach if it is a bulky tumor going into the stomach. But as per the NCCN, the type 1 and type 2 should be managed as esophageal cancers. So removing the stomach means you need to remove the lymph nodes of the stomach also. So this is probably a departure from what the NCCN says because of your experience, or is it like this is the way the next like people discuss about, because I was thinking like type 2 is totally esophagectomy, but you told in this presentation that if the extent of the tumor is in stomach, then probably stomach also has to be removed.
Yeah.
So
So yeah, basically, that is the problem with the Sievert's classification, is that type 2 can involve a significant part of the stomach also.
yeah.
And therefore you will compromise on the circumferential margin if you make a
Yeah.
conduit out of the stomach. You may, if you still do it, you will be leaving the suprapyloric and infrapyloric lymph nodes, which will not be part of your resection. And again, that can be a problem. So I think of the three, the three questions. One is the upper extent, the mediastinal lymph node dissection. But the third one is also very important, which is, can you use the stomach as the conduit? And that is determined by will you be able to give adequate margin for your conduit? Like if you're going to use the stomach as a conduit, if there is involvement of the fundus or a significant part of the body, or all that will determine whether, because otherwise you're going to have a positive margin along your staple line or your stomach conduit line.
Because the margins should be always circumferentially, it should be more than 2 to 5 centimeter, like all the angles.
Yeah, at least
or towards the body also, towards the fundus also, everywhere.
Yeah, towards in the body to at least a centimeter. 2 centimeter may not be possible, but at least a centimeter is necessary. But I think for a type 2 doesn't necessarily always involve one or the other. It also depends on the extent of stomach involvement.
Because actually what we get is that kind of bulky tumors, and we give neoadjuvant, and finally we don't want to do a esophageal-gastrectomy. We want and do a colonic conduit. So that's why these all questions come up, because we like to do a simple preserve the stomach as a conduit and do a neck anastomosis. So that causes a problem when you have a bulky tumor initially. Even after neoadjuvant, we have to remove, as like you said, you have to remove a wider margin.
Yeah.
Even after neoadjuvant.
Yeah, and whether it will be safe, where you transect the stomach, where you get the stomach, is also as important as the proximal and distal margin. So if you have that in mind, then I think it's easy to decide.
Thank you.
Good evening, sir. May I ask, sir?
Yeah, please.
Yeah, I'm a surgical gastro resident, sir, from Narayana Medical, Nellore. Sir, in the presentation, you said that in Sievert 2, that if the tumor is more than 2 to 3 centimeter from GOJ, we have to go in the thorax. Sir, what I wanted to know that if it is say 2 centimeter above the GOJ, now after this also we need a proximal 2 to 5 centimeter margin. So how feasible it is that to go from the abdomen and get that margin, and even after that fashion anastomosis? So won't it be that invariably we are going to enter the thorax, sir?
Okay. So basically, I think you're talking about the difficult situation where you're not sure whether you can do from the abdomen or whether you need to get into the thorax.
Yeah, those borderline situations, sir.
Yeah, the borderline. So essentially, if you have let's say if it is 2 centimeters above, you will be able to mobilize about 5 centimeters of the esophagus in total from the abdomen, roughly. I think that's sort of the ballpark figure. So you have a 2 centimeter or 3 centimeter tumor above the GOJ, you will add another 2 more centimeters, which is 5, which is the limit of what you can do through the abdomen. Now, if you have a thin patient who is favorable anatomy, you will still be able to achieve the anastomosis through the abdomen. Perhaps using an Orville or perhaps using those kind of techniques. However, if you have an obese patient, the same scenario will not be possible. So in that situation, you will need to go into the chest to at least do the anastomosis. Forget about the lymphadenectomy. So, and for that, you the chest or into the right chest to do the anastomosis.
So welcome all the panelists. Dr. Inian, Dr. Sandeep Batra couldn't join. Dr. Saurabh, Dr. Biswajit, Dr. Joseph, and Dr. Abhishek Gulia. So among us, we have 3 surgeons, 1 medical oncologist and radiation oncologist. So it will be a nice MDT discussion. So when we talk about GE junction cancer management, it's a complex issue. So management takes into account the performance status of the patient, the location of the tumor, the subtyping, the histology, whether it is squamous cell or adenosine, and also the extent of stomach and esophageal involvement. So 2 aspects where there is a lot of discussion, a lot of confusion. What neoadjuvant treatment to choose and what surgery to perform, approach, extent of surgery. So broadly speaking, so this diagram we have seen so many times. Broadly, type 1 Sieverts is managed as esophageal cancer, type 3 as stomach cancer, because majority of type 1 is squamous, majority of type 3 is adeno. But this gray zone, type 2 Sieverts classification, subtype is the real problem, and it's the reason of all confusion. So if we talk about neoadjuvant, choice of neoadjuvant treatment, subdividing as per Sieverts and histology. So type 1 squamous cell, definitely most of the places, most of the centers, they choose, they give neoadjuvant CTRT. Type 3 adeno, most of the centers, no confusion, neoadjuvant chemotherapy. But others, there is plenty of doubt, plenty of discussion. So I'll be discussing the majority of aspects through case-based discussion. So simply put, a 50-year-old PIT patient with grade 1 dysphagia, GE junction cancer, squamous cell carcinoma, Sieverts 1, non-metastatic, radiologically T3 node positive disease. So we did a MDT and we decided for neoadjuvant treatment. Now, what neoadjuvant treatment to choose? Dr. Abhishek Gulia. Dr. Gulia.
Yeah. Hi.
Yeah.
So I'm sorry, I couldn't see whether it is a adenocarcinoma or a squamous.
No, it's a Sieverts 1 squamous cell carcinoma.
Right. Then I'll go for neoadjuvant chemoradiation.
Yeah. So there is a plenty of discussion. I saw a question in the chat box also. What neoadjuvant treatment to choose for type 1 squamous or whether NSCT or NSCTRT. So Dr. Biswajit.
So if it's a squamous cell, we would go with NACTRT. But there is a small clause in this that what will be the length of the lesion, because sometimes our radiotherapies are not comfortable if the lesions are more than 7.5 centimeter to 10 centimeter, then there's a large, I mean, if the lesion is too large, then it's difficult to radiate. So then we do NACT and we don't do NACTR.
So
as far as the field length is concerned, I think that was more of an issue when we used to incorporate brachytherapy intraluminal in the times of when we used to say that we used to escalate dose after external radiation, we have to give intraluminal, and by brachytherapy we will not be able to cover such a large volume. But nowadays when we are practicing conformal radiation, I think we can fairly radiate. We can radiate larger volumes also.
I mean, this is what we follow at our center. So
right.
If it is 7.5 to 10 centimeter beyond that, then we generally give NACT. If it's below 10 centimeter, then we do NACTR.
Okay. Dr. Saurabh, so we as a surgeon are very, very much concerned about the RT field, whether especially in case of GE junction tumors, where the stomach, a part of the stomach will be irradiated. So, and this stomach will be, in future, it will be used for making gastric conduit. So, Dr. Abhishek, Dr. Gulia, can you throw some light on the radiation field, how much stomach is irradiated?
Yeah, definitely. So in a Sievert type 1 case, I'd like to have a minimum of around 3 to 4 centimeter proximal margin in the esophagus. and a 2 to 3 centimeter distal margin. But we'll have to have a discussion with the surgeon beforehand that whether he's planning to go for a gastric conduit later on or not. Because if I radiate the fundus, as they tell me, as my surgeons tell me, if I radiate the fundus, they'll not be able to use that as a conduit. So I make sure we have a discussion that the fundus part is I contour it as an avoidance, and it's not radiated, nor as a target volume, and nor inadvertently. As far as the radial margins are concerned, I think 2 centimeters is enough. The 2 centimeters is enough to cover all the periesophageal lymph nodes, and the celiac lymph nodes also I'd like to cover in these cases, and perigastric, of course.
So Dr. George, so do you find any operative difficulty in these kind of tumors where a part of stomach has been irradiated? Operative and as well as like by making conduit, do you find that it is the stomach is edematous and all?
Yeah, from my experience, for Sievert's 1 squamous cell carcinoma, what we usually follow is after neoadjuvant chemo radiation, we go in for a thoracoscopic esophagectomy and use the gastric conduit and do a neck anastomosis. Mostly we've found the stomach to be okay. Probably as our probably our RT people also don't irradiate the fundus. So I have found the stomach to be quite okay. So this is the protocol that I use.
So Dr. Saurabh, as a surgeon, what would you prefer? Radiation, coming back to the this thing, what would you what neoadjuvant treatment would you prefer? Neoadjuvant chemotherapy or neoadjuvant chemo radiation? Dr. Saurabh?
Hello. Yeah. I'm saying there's no preference. Whatever neoadjuvant therapy has been given is decided by the oncological advantage. So if you have a neoadjuvant chemo radiation versus chemotherapy is decided by the all the specialists together, because some people are not able to tolerate a chemo radiation because of probably a poor performance status, or they are very old. So people then go for a chemotherapy also. But for a surgeon, we have to deal with it finally. So whatever we get, however the patient is there, we have to manage them. So it's not a preference for us.
So, right. So the oncological principles and the tumor control is the primary important.
Yeah.
So Dr. Biswajit, just a question. So many centers are practicing still, they are giving a neoadjuvant chemotherapy for GE Junction squamous cell carcinoma. So there are multiple protocols which are going on. So if we have to choose a chemotherapeutic regimen, so what do you use and how do you use? How do you choose?
So it all depends on the histology. If it is a adenocarcinoma, then it is FLOT or the magic trial, which is the ECF or the EOX. And many of us now believe that epirubicin does not work, so probably Folfox is also a good choice. So FLOT and Folfox are 2 things which you give if any patient with adenocarcinoma. If it is squamous cell carcinoma and we are planning for an NACT-RT, then it is obviously carbo plus paclitaxel. Though there is some data that in squamous also you could use in adenocarcinoma also you could use paclitaxel, because in the cross trial there were patients who also received CT-RT for adenocarcinoma. But that's again a question of debate whether we should do NACT-RT for adenocarcinoma or we just do NACT for adenocarcinoma. At our center, any adenocarcinoma, we just do NACT, we don't do NACT-RT. And for squamous, we do NACT-RT, that is with carbo and paclitaxel.
So just a hypothetical question. So sometimes like if we get a scenario like type 1 adeno-CA, what neoadjuvant treatment would we choose?
Yeah.
So
Dr.
Biswajit,
sorry.
Yeah, Dr. Biswajit, I was saying.
So as I was saying, if it's adenocarcinoma, we just go with NACT. We don't go with NACT-RT.
So Dr. Gulia, any disagreement?
At least in Sievert type 1, we are pretty sure we go for neoadjuvant chemo radiation. We treat it like esophagus based on the cross protocol. And in Sievert type 2 also, we tend to go for NACT-RT only.
So just one comment is that in the cross trial, actually the squamous histology did well. So the adenocarcinoma data with CT-RT is still not very great. So if it is adenocarcinoma, I'm not again convinced that NACT-RT will really help when compared to just giving chemotherapy.
So as a general rule, we are treating Sievert's type 1 and type 2 as esophagus. And of course, adenocarcinoma does make a difference, because in Sievert type 3, even if it is a squamous cell carcinoma, we try to go for NACT-RT. But yeah, I know the maximum benefit was derived for squamous variety, but for the adeno also it showed improvement in benefit. So this is what is followed in our institute.
So Dr. Inian, have you ever encountered type 1 adeno-CA like a problem in choosing neoadjuvant treatment, NACT versus NACT-RT? So this is a proximal location with adeno-CA histology.
In our institute, what we follow is for adenos, we give NACT, even if it's a Sievert's 1, 2, or 3, doesn't matter. For squamous cell carcinomas, we go for the cross regime. So in this scenario, we would go for FLOT as our preferred regimen. Now, having said that, just with your previous thing about the squamous cell carcinoma, if the SEC is more than 2 centimeters into the stomach, we would still go ahead with NACT rather than NACRT. That is just from our surgical perspective. We ask our radiation oncologists, and essentially we would avoid radiating the fundus. So that would be for a SEC. But in this scenario, I think we would give NACT.
Yeah. So we'll move further. So for squamous, we give NACT-RT followed by surgery. What is the time interval would you prefer from neoadjuvant treatment to surgery? Dr. George and Dr. Saurabh.
Yeah, actually it's 6 to 8 weeks, or probably sometimes more than 8 weeks also. But it's not always the norm. Some people come very late after NACT-RT because they have a very good response, and we have to deal with it whenever they come. But ideal time is 6 to 8 weeks probably.
So everywhere, whether it is esophagus or rectum, we are just delaying the time interval just to achieve more PCRs. So Dr. Gulia, comment on that.
I'm sorry, me?
So Dr. Gulia.
Yeah, so 6 to 8 weeks is what we usually advise and follow.
So Dr. Saurabh, you are saying something. Sorry, I interrupted.
No, I've already completed. Like 6 to 8 weeks is ideal time, but sometimes the patients take time to recover, and they need optimization for surgery. So we may need to postpone it also. If the patient is not doing well, his nutrition is poor, he has some chest complications before surgery. So sometimes we can delay it after 8 weeks also. But ideal time is around 6 to 8 weeks from completion of NACT-RT.
So now extent of question on the extent surgical aspects. So extent of resection. So Dr. George, how do you decide on the extent of resection? How much esophagus to remove? How much stomach to receive? I know Dr. Inian has already covered, but word from your side.
Yeah, so the practice that we follow in our institute is somewhat similar to what Dr. Inian had suggested. Sievert 1, even if it is squamous or adenocarcinoma, especially the one, before I just want to make this point that Dr. Inian, what he suggested about the epicenter and the longitudinal extent, the difference between the epicenter and the longitudinal extent. That's a very crucial decision-making aspect while deciding about the resection. So even if the epicenter is lower down, if it's extending into the esophagus to say around 4 centimeter, then there is a chance that at least the mid-mediastinal nodes might be involved. So in those cases, I would always go for a transthoracic esophagectomy and a neck anastomosis. Only in rare cases where even the fundus is involved, that's a difficult question, like what Dr. Nikhil was suggesting. In that case, I might, if depending upon the situation of the patient, if he is like a fit patient, I would go ahead and do a colon interposition. Otherwise, I would just stick to a Ivor Lewis with a jejunal conduit. For Sievert 2, if the esophageal extent is not much, I would stick to total gastrectomy, and through the thorax, through the hiatus, I'll try to dissect the lower mediastinal nodes. And what I usually do is I do the anastomosis somewhere just below the subcarinal region using an orbital. So I always take a bite, even if it is minimally invasive or open technique. Before dividing the esophagus, you take 2 stay sutures and then divide it. And then I would proceed with a jejunal conduit. Sievert's 3 is straightforward total gastrectomy, and just if the esophageal extent is higher up, again you'll have to go a little bit higher up into the thorax and anastomosis it. So and in cases of Sievert 2, where it's, the involvement is GE junction and mostly the 2 centimeter or 3 centimeter of the esophagus. If the patient is not very healthy, is an older gentleman, or then I would rather do a transhiatal esophagectomy.
So, Dr. Saurabh, Sievert's type 1 squamous cell, what do you practice? Transthoracic TT or like Ivor Lewis? How do you decide on the margin?
You're saying squamous cell.
Yeah,
squamous cell is like
yeah, type 1 squamous.
Yeah, so it is like a total esophagectomy, like what Dr. Inian said, and we do a neck anastomosis, because squamous has a totally different like pathology and the spread. So we have to do mediastinal dissection, mediastinal lymph node dissection. So I do a thoracoscopic esophagectomy and remove the nodes from the carina level down, and do a stomach mobilization by open or lap, and then pull it up and do a neck anastomosis. So that is the standard technique.
So how you decide on the
margin? Obviously, like you have to have a proximal margin. So if you have a even a one type 1 squamous cell carcinoma, the margin is long, because esophagus is quite long, and if you do just a neck anastomosis, you will have a good 5 to 10 centimeter margin proximal to the lesion. This margin is not a problem when you're removing the esophagus, because stomach will come up into the neck.
Okay. And in suppose that if it is adeno, what about distal and proximal margin? Like it's like,
yeah. So adeno also, like type 1 is treated as a esophageal cancer. So it is supposed to be treated as total esophagectomy. But like what Dr. Inian said, type 1, if you have a type 1 and stomach fundus is involved, then what will you do? Because sometimes the tumor goes into the stomach and towards the fundus, and it is the epicenter is higher up. It's a big tumor. Then what to do? So that is a still a controversial thing. Should we remove the proximal part of stomach? Then stomach will not come up, so it will has to be a Ivor Lewis. Then the margin has to be compromised, or you do a total esophago-gastrectomy and do a colonic conduit. So even in type 1, if the stomach is involved in the lesser curvature or the fundus part, then the conduit part has to be decided, and the lymphadenectomy has to be decided. So that is a problem.
Right.
Otherwise, standard esophagectomy has to be done in type 1.
So rightly said, the longitudinal extent is also equally important to decide on the extent of resection and also the extent of mediastinal lymphadenectomy. So approach. So what approach do you prefer, Dr. George?
Yeah, for esophagectomy, I usually prefer thoracoscopic esophagectomy. The abdominal component may be an open or a lap, and I usually follow the McEwan and do the neck anastomosis. Most of the cases where I had to do a distal esophagectomy, I have dissected through the hiatus, and using an Orville, I've done the anastomosis. Using an Orville is a little tricky. Sometimes we do feel that the anastomosis might give way, but thankfully it's sort of not given much of a problem. In a really difficult situation where you have to really go higher up, like at the, just beyond the subcarina and all, then I would put a left thoracoabdominal incision and do a classical Liver-Lewis.
So Dr. Inian, any comment on left thoracoabdominal approach?
No, I would agree with what Dr. Joseph had just mentioned. So basically, our approach would be for a squamous cell carcinoma, it would be starting in the thorax and doing a thoracoscopic McEwan's esophageectomy. If it is adenocarcinoma, and if it is, let's say, a Sieverts 1 or a Sieverts 2, and if the stomach can be still used, then we would still do Ivor-Lewis, minimally invasive Ivor-Lewis. For a minimally invasive Ivor-Lewis, the lymphadenectomy, we don't go into the supracarinal, but for a McEwan's, particularly for SCC, we do the supracarinal lymph node dissection. So that would be our approach based on the histology and based on what we would do. In terms of using the stomach as a conduit when you do an Ivor-Lewis, it really depends on the how much of stomach is involved, as Dr. Joseph and Dr. Saurabh earlier was alluding to. It's very important to make sure that you have adequate margin circumferentially also on the stomach, particularly when you're doing an Ivor-Lewis esophageectomy. If it is not the standard one of these two things, then obviously it will be an open. Like if it is really in doubt, and if we think the margin is going to be difficult, then we just do an open either total gastrectomy and then convert to a Ivor-Lewis if necessary. So those borderline cases we do it open.
So one more aspect, extent of lymphadenectomy has been nicely explained by Dr. Inian, so I won't be rediscussing again. So now moving on to the second case. Similar patient, 55-year-old lady, fit patient, GE Junction, Sieverts 2 adeno-CA. Again, MDT decided to give neoadjuvant treatment. Again, coming back to Dr. Biswajit and Dr. Gulia.
Adenocarcinoma in SCT. No adjuvant chemo with what?
Dr. Gulia, any disagreement?
Yeah, basically it also depends upon the extent of lesion, of course. But in Sievert type 1 and type 2, even though it is a adenocarcinoma, we tend to go towards NSCT-RT. But of course, we have to see whether we'll be able to, what is the extent of disease, whether we'll be able to spare the fundus or not. And then sometimes we can go for NSCT also. But for this lady, I'll go for NSCT-RT.
Dr. Biswajit?
So I think there is some data, and the head-on-head trials are not very great, but whatever meta-analysis are there, and there are 3-4 trials which says, I mean, either way you go. One trial was interesting where they gave induction chemotherapy and followed by the CT-RT. So in that study, they showed that if you give some induction chemotherapy followed by the CT-RT, the survival rates were higher than doing just giving the NACT. But it is not exactly the same as giving NACT-RT and RT. I mean, NACT-RT versus NACT. But again, the issues are that we should always understand that the mortality rates, I mean, the treatment complications and post-op mortality also is slightly higher when compared to CT-RT, when compared to CT. So, and as Dr. Inian just said that the New Ages study which just came out, the results are just out, and it says it is equipoise and your float is doing as well as doing the NACT-RT. So in that situation, I would still favor towards NACT, but again, things are open. It's institutional policy to decide.
those trials which Dr. Biswajit just discussed, I think that is very I think that is going to be the future. But the only problem with those trials in which they have used induction chemo around 6 weeks, and then they have given preoperative CTRT, and then they have moved to the surgery. The issue with these trials is they delay the ultimate treatment. The main treatment is surgery. And with this approach, especially in non-responders, if somebody is non-responder and we are doing so much of chemo and then chemo radiation, ultimately it becomes inoperable. Then the whole point of doing such a long neoadjuvant treatment is lost. But I think that's a good approach. In another trial I was going through was that they checked for response on a PET scan. Interim PET scan was done. But the responders were continued with the chemo radiation with the same, with the set chemotherapy schedule. And in non-responders, the chemotherapy schedule was changed. And ultimately, of course, the morbidity has to be balanced out in these trials.
I think one more point to cover is that one advantage of doing NACT-RT is that if your PCR rates are going to be higher with NACT-RT, the advantage is that now with the nivolumab study, which says that if you are having NACT, if you're not having a pathological CR, then the nivolumab has to be used because it shows benefit. Whereas if you do not have a pathological, I mean, if you do not have a pathological CR, the nivolumab works. If you have a pathological CR, the nivolumab does not work. So maybe that if you have more pathological CRs, there might be a possibility that you might be doing better survival. It's not yet proven, but that might be one area where, because with NACT, the pathological CRs are much lesser when compared to NACT-RT.
Right.
Actually, can I interrupt here?
Yeah, please.
Just, this is addressed to both Dr. Abhishek and Dr. Biswajit. See, my understanding of let's say the cross regime, NACT-RT, the radiation component and the chemotherapy component. The chemo component is basically a radiosensitizing dose rather than looking at it as a systemic chemotherapy. Now, my problem with this, for giving this for adenocarcinoma, it's okay for squamous cell carcinoma, but if you are only giving a radiosensitizing dose, which means that it's predominantly local treatment, and you are actually helping with the local treatment by giving the chemotherapy. Whereas if you give systemic chemotherapy, that is a completely different kettle of fish. So I just want to throw this to both the oncologists here. Am I wrong in considering this? I know the studies have shown, even the cross trial has shown good pathological response with adenocarcinomas. But my, my gut feeling is basically, are we giving enough systemic chemotherapy when we give NACT-RT, the chemo component of it, and is it adequate for adenocarcinomas? Is my question.
Well, as far as I take it, paclitaxel and carboplatin, they are radiosensitizing, but not only they have a radiosensitizing effect, they have an independent tumoricidal effect on their own. It's a fairly intensive chemotherapy. We cannot say that it only has a radiosensitizing dose. It does have tumoricidal effect, and probably because of this, they are now trying to incorporate a chemo followed by neoadjuvant chemo radiation schedule. But I think it has independent tumoricidal effects on its own also.
I think I agree with Dr. Inian, and that is the philosophy why we generally use in any adenocarcinoma NACT and generally don't CT-RT. So in a squamous, it's completely different. I totally agree. But in NACT, I think chemotherapy is important.
Right. So Dr. Biswajit, we have two very popular regimen, FLOT regimen, MAGIC. Everyone talks about it. How do you choose which chemotherapeutic regimen for which patients?
Yeah, so I think there is already enough data. We have a randomized data with FLOT, and definitely FLOT is superior to doing EOX or CAPOX when compared to FLOT. So that is no doubt that the FLOT is good. But again, we should understand that the FLOT is not a very easy regime to give. And in an Indian situation, whether the FLOT, we are going to give all patients FLOT is again a challenging question, with nutrition being a problem and the full doses of FLOT being an issue. So I think in our setting, we still need to individualize case by case basis, but a fit patient, no question, FLOT is the drug of choice.
So sometimes we do encounter, strange histologies. So GE junction type 3, this is the type 3 squamous cell carcinoma. We had 2 patients in the past 2 years, and there was a lot of discussion what neoadjuvant neoadjuvant treatment regimen to choose. Type 3 squamous cell carcinoma. Dr. Gulia.
In type 2 squamous?
Type 3, so this is a typo error. Type 3 squamous cell carcinoma.
In squamous, we tend to go for like, I may consider a type 2 Sievert's adeno for FLOT or a perioperative chemotherapy, but in squamous cell carcinoma, we are pretty clear. We go for neoadjuvant chemoradiation.
So Dr. Biswajit, type 3 squamous cell carcinoma.
Yeah, again, any squamous preferred for CTRT, but again, my radiation colleagues are not very comfortable when it touches close to the stomach. That's what generally when we have the tumor board discussion, if it is somewhere closer to the, type 3, most often we try going with NACT and not with NACTRT. That's what we do at our center.
So similar experience at our center. So two instances we had this histology, type 3 squamous cell carcinoma. We had plenty of discussion. Finally, the tumor board decided to give neoadjuvant chemotherapy. So Dr. Inian, have you encountered similar situations at your center?
Yeah,
type 3 squamous cell carcinoma.
Yeah, certainly in this situation we have encountered, and we would give NACT for these patients purely because basically, the surgical, should I say the fear, we don't know if it is right or wrong, but traditionally we've been doing it. So if it involves more than 2 centimeters of the stomach, if it is squamous cell carcinoma, we would go for neoadjuvant chemotherapy. And I think, we might be wrong, but this is our practice anyway.
So we don't have a clear answer to this. So Dr. George, Dr. Saurabh, just a quick, any experience with type 3 squamous cell carcinoma?
Yeah, I've seen some cases, but should be managed as stomach tumor. So stomach cancers generally chemotherapy is preferred. So if they have to give neoadjuvant, then probably chemotherapy is what I would prefer.
Yeah. So complex interplay of location and histology. So so again, extent of resection has been already discussed in detail and covered by Dr. Inian, Dr. Saurabh, and Dr. George. So I'll moving on to the next slide. Similarly, margin. So just a quick recap, Dr. George, how to decide on total gastrectomy, whether to do a proximal gastrectomy versus total gastrectomy in type 2 adeno-CA?
Yeah, so the extent of involvement of the stomach would be the answer. If it is more than say 3 to 4 centimeter, there's always a risk of the nodal involvement along the greater curvature. So in that case, you have to definitely go for a total gastrectomy. And there is this, so sometimes like the last case that I had done when the endoscopy had shown Sievert's type 2, where we had given a neoadjuvant chemotherapy. There was an involvement of the fundus of around 1 centimeter. The distal esophagus was involved for around 2 centimeter. Unfortunately, when we went inside, on actually palpating, what we could feel the tumor to be extending along the lesser curve as well, though it was not very evident on the CT or on the endoscopy. So it's very essential that once you rule out there is no peritoneal carcinomatosis or dissemination, you have to palpate the stomach properly and make sure what exactly is the involvement. If the body is involved, if the fundus is involved, or if at least the cardia is involved for more than 3 to 4 centimeter, I would always go for a total gastrectomy.
Right. So approaches we have already, approaches in lymphadenectomy we have already covered. So just concluding, so thank you very much all the panelists and Dr. Inian, of course. Excellent discussion. And Dr. Nikhil, over to you. Hello.
Thank you, Sanjeev. Excellent discussion. So you brought out all the pertinent points, and I think it would have been very helpful for all of us, leave alone the young surgeons and residents. And it's been 6 months we have been doing this program. It was exactly started on 2nd of December, and we are like overjoyed with the participation of both faculty and students. So we hope to continue this, and next webisode and series we are discussing liver. So hope to see you again. Good night, everyone. Thank you very much.